So the next patient is a esophageal squamous cell carcinoma. This is a 74-year-old gentleman, which unfortunately I've covered my my image there. With presents with progressive dysphagia and a mild weight loss. He's excellent performance status. He still works as a banker. He has on CT and PET scan. He has a clinical T3N1 esophageal squamous cell carcinoma. So what's our first poll to the audience is for esophageal, a locally advanced distal third esophageal squamous cell carcinoma. What is the management? Is it surgery, neoadjuvant chemotherapy, neoadjuvant chemoradiation therapy to 41.4, neoadjuvant chemoradiation therapy, and then treatment based on response, and definitive chemoradiation therapy to 50.4. So let's start off by asking the panelists. John, this is distal third squame. How would you manage this?
I'd manage it with, in a fit patient, I'd manage it with multimodal therapy because our best outcomes, about 65% five-year survival and cure rate is with that. In an unfit patient, and we've kind of clinical equipoise and are happy to go with definitive chemoradiation.
Simon, in Hong Kong, how would you manage this?
Well, I guess the standard would still be neoadjuvant chemoradiotherapy with a cross. However, I think Mark from Amsterdam has already talked about the distal location of the tumor. It does mean that the radiation might involve part of the stomach, which we really don't like. Looking at the films just now, I think that cancer can be readily resectable even without radiation. So it will be either upfront surgery or we would actually give preoperative chemotherapy. So I guess in Japan, it may be PF is still standard. Having said that, in our past experience of a randomized controlled trial, using 2 courses of platinum and 5-FU, that didn't really make much difference. I think these days we have shifted more to DCF. So giving a triplet and then followed by surgery may be an option in this patient.
And Yuko, what would you do with this kind of a patient? What neoadjuvant therapy would you give?
You're on mute, Yuko.
So I know that chemoradiation, neoadjuvant chemoradiation is a standard in the rest of the world. But in Japan, neoadjuvant chemo is a standard. So at this moment, I will show you later the current study, but at this moment, and neoadjuvant chemo by 5-FU cisplatin is a standard in Japan for this case because resectable and then controllable, and curative surgery has very good effect for this patient. This is our current standard.
Wayne, I understand. Wayne, could you respond here? I understand that in MD Anderson you do not use. You mentioned this a little bit earlier. You don't use the cross-trial data. You use your own your own approach. Can you comment?
Well, yeah. I mean, we would use, although you guys have as the last option is definitive chemoradiation with 50.4. We use 50.4 as multimodality therapy and then reevaluate. And as Mark said, depending on the status of the patient, it's a shared decision-making process between whether or not the patient, has had a complete response clinically, whether they want to go to surgery, and how fit they are after chemoradiation, because sometimes their performance status is quite low. So if they've had a complete clinical response and they're not a great candidate for surgery, we would tend to observe at that point. And, I would agree that multimodality therapy may be better, but that's often an issue of selection bias. We use 50.4 because the older data from the Herskovitz trial was 50.4, and that was followed up by the intergroup trial showing that more radiation at 60 was not better. In fact, it was potentially harmful. And so we've been using multimodality therapy since 1997, and that was long before Cross came out. We've been successful with 50.4. So that's been our regimen.
Wayne, is it still a weekly carbotaxol, or do you go back to your cisplatin 5-FU?
So cis-5-FU has kind of been out of favor with us for about the last decade. So right now it's Folfox. And the reason that our oncologists don't use FLOT up front is that they complain that that's using 2 lines of therapy up front. So they want to have the option of having their second line of chemotherapy for failure. So we've talked a lot about FLOT. They're at this point using Folfox and then using you know, the taxane or something for a second line, or using a taxane up front and then, you know, having something in the background for a second line.
Mark, do you want to talk about the poll results?
Well, the poll results show that the majority of people uses cross as neoadjuvant therapy and probably then surgery. So I think that's interesting to show.
In this patient, we use neoadjuvant chemoradiation therapy with a traditional cross regimen with carbotaxol, weekly carbotaxol with 41.4 gray. Yuko, I was wondering if you can comment a little bit on the approach you mentioned about the use of chemotherapy, because in Japan and also in Hong Kong seems to be a bit more of an approach, employed approach rather than the rest of the world where chemoradiation therapy seems to predominate. Can you comment a little bit?
Okay, you know, basically we believe that you know, local control by very intensive surgery using 3-field or modern type 2 field are very effective. And then now current standard in Japan is neoadjuvant chemo using 5-FN cisplatin. But for stage 3, we need more, you know, power for neoadjuvant treatment. And then we just now comparing DCF triplet and chemoradiation like Western style. And then the result we will see the result in next year, 2021. If chemoradiation is a winner, we are 30 years behind of your countries, Western people. But you know, if you can see the, you know, superiority of DCF, so the systemic treatment with very extensive surgery will be very effective. So nobody knows. But recently, we are just trying to introduce FLOT to squamous, not for adeno, as a phase 2. And also we are trying to use neoadjuvant and chemo using 5-FN cisplatin or DCF with Nivo, immune checkpoint, as a phase 1 to check the safety. So basically we have to look at the result of next trial.
Very good. So if I understand, Yuko, it's right now it's chemotherapy, either cisplatin 5-FU or docetaxel cisplatin 5-FU. And the trial will be compared to chemoradiation therapy, and that will move forward whether or not, if you think a local therapy with en-bloc 3-field esophagectomy can replace radiation therapy as an extra local modality.
That's right.
Yuko, can I ask you a question?
Yes.
Do you have any concerns of the use of radiotherapy in combination with extended surgery? Were there any concerns before starting the trial?
So I think, you know, 20 years ago, you know, we have some serious complication by radiation therapy. But now we know that irradiation technique was very, you know, successfully improved, and then toxicity is very low. Maybe, I don't think, you know, neoadjuvant chemoradiation is very harmful, but still we have to, you know, compare the long-term results. This is our point.
Absolutely. Okay, shall we move on?
Yeah. Yes. So it's a little bit of comment on radiation field. I think the traditional, Mark, can you comment on what's the traditional cross radiation fields that were done in the trial in which you, I think, enrolled around 1/3 of those patients? What were the radiation fields for a patient like this?
Yeah, so the radiation field would involve the tumor, but that was not supposed to be longer than 8 centimeters. No gastric involvement more than 2 centimeters. And of course, there was also the radial limit was 5 centimeters. So I think if you compare to what we do now in RMMDT, probably the radiation fields that were used in the cross were probably smaller than we use or tend to use right now. For example, if you look at your patient here, there would be radiation field also to the lymph nodes near the left gastric. So they would be involved.
So John, I was wondering if you can comment a little bit about what do you think the secondary effects of radiation on the body, how does this impact surgical outcomes and postoperative outcomes or long-term effects, the choice of radiation field?
Well, it's controversial, but there's obviously some data that some of the extra deaths that are seen in some of the trials that have been done, even though it might not be statistically significant, relate to the radiation effect, maybe idiopathic ARDS. And clearly a small percentage of patients have long-term pulmonary or cardiac complications from it. But I do think that radiation as it's delivered nowadays is a different therapy, very much so, compared to even maybe 10, 15 years ago. So it's getting safer and safer and more focused increasingly.
So just for a hypothetical point here, so this gentleman, if he had been seen at MD Anderson, he would have had an endoscopic ultrasound. He would have found an extra lymph node higher up in the high periesophageal area, intrathoracic. So how would this impact the radiation field? Wayne, I wonder if you can comment a little bit. Would you try to include it all in one massive field, or would you try to think there's no skip metastasis? How would you do this? Would you do this as a separate fields, or would you manage it with a combined continuous field like it is on the left-hand side of your screen?
These are problems, and one that are discussed in multidisciplinary conference frequently. And when a radiation oncologist sees this, that I think it brings a lot of anxiety and trepidation, because in our setting, the radiation oncologists feel like they need to be responsible for curing the patient. And you'll see, PTVs or the radiation treatment plans looking like the one that you're showing over on the left. Patients don't tolerate that radiation very well. That's kind of a go for broke attitude. So in patients that we feel are potentially salvageable with multimodality therapy, or that we can at least give them a shot, we will interrupt the field and go after the standard therapy field in the lower esophagus GE junction, and then use a spot field up above. Or even in some situations with me, I will tell them, leave the lymph node above alone. Don't even radiate it. Let me take it out surgically. You take care of the primary, and I'll take care of the distant lymph node. But I do not like those fields that you show over on the left, because more often than not, the patient's so beat up, we can't get them to surgery afterwards.
Simon, can you comment a little bit on how would you manage this gentleman here? Would you try to include all in one field? Would you do something different? Would you do discrete fields?
So you know that this type of patients is, of course, not uncommon in our setting with a squamous cell cancer in the distally, and typically it would have an apical lymph node, say the right recurrent laryngeal nerve lymph node. So our oncologists usually will try to, something wrong with my computer.
We hear you, Simon.
We can hear you.
You can hear me, but I can't see the screen somehow. Hang on a sec. I think I've lost you. Sorry, I need to log out and log in again, I think.
We can still hear you, Simon.
Oh, yeah,
Could you just comment on your...
I'm back. So firstly, this is a typical situation. So our oncologists, usually they try to have one field, includes everything. But like what Wayne said, this is really too big. So the option would be either do a split field, do the primary and do a separate field for the apical node. But having said that, I think what determines our treatment also, we need to look at the primary tumor. I think for this particular tumor, it looks readily resectable, even without radiation. So in this particular patient, we would go for chemotherapy, actually, rather than chemoradiation, and the surgery would take care of the rest.
And would you consider changing that if it's a larger, more bulky tumor, maybe a little bit higher up? Would you change your strategy?
So right. So if the primary tumor, we say that it is bulky, it is borderline resectable, then we believe that we need the radiation in order to convert it to a resectable, readily resectable tumor. So in those patients, we'll probably give chemoradiation to the primary tumor. For the separate lymph nodes, then the option would be either like what Wayne said, leave it alone, and then we'll deal with that surgically later on, or use a split field, rather than having a huge radiation field with this attendant side effects.
Okay.
Okay, so
Let's
I think
move on.
Let's move on. I think I agree. We tend to do either discrete, or we tell the oncologist just to include, not to include the radiation oncologist, not to include this one, that we will resect it. Otherwise, I agree that this field, as Wayne said, is horrific. Okay,
Yep.
so this gentleman had, again, excellent performance status. He had carbotaxol weekly, 41.4, cross regimen, endoscopy is right there. You can see a complete resolution of the endoscopic image. On biopsy was negative, CT scan, mild residual thickening, which you can see down here, and PET scan, complete resolution of increased SUV. So now the question of the panel is, do you resect this patient, or do you continue active surveillance? And if you do active surveillance, what do you do in these patients? What do you do to confirm that this is a complete clinical response? Wayne, you seem to be more of a salvage, a selective surgery gentleman. Can you please comment on what you would do and how you'd make sure this patient has complete clinical response? Would you do EUS? Would you do biopsies? What do you do? And finally, what's your active surveillance protocol for people who are clinically responsive after chemoradiation therapy?
So I'm going to try to keep this answer as short as possible so you don't cut me off, but this is really kind of a long-winded answer, which is patients who have CCR, we engage in a shared decision-making process and saying, you've had a complete clinical response. In squamous cell cancers, you have upwards of a 50% possibility that you've had a pathologic complete response to go along with the CCR. I will tell patients that I would prefer to do surgery on patients who are fit, especially if the tumor was initially behind the airway, because we've seen local recurrences on patients that weren't referred over for surgery get into the airway and become unresectable, and losing them to local disease is a complete failure. However, in this situation, the patient has distal disease. And so the question is could they undergo observation? And if they were later found to have local or regional recurrence, could they undergo successful salvage surgery? So this is something that we're publishing on currently in squamous cancers. Obviously, the Asian groups have published on this extensively. But I will tell you that our institution, if they've had a complete response, we will have a discussion, and many times patients will decide not to have surgery in situations like this.
I'm going to push you a little bit more than that, Wayne. In your discussions, the patient says, whatever you say, doc, whatever you say. I know that doesn't happen to MD Anderson, but it happens here a lot. What's your recommendation?
We look at the patient, quite honestly, Lorenzo. So, or at least I do. So if I've got a 50-year-old patient who I think I can walk them through a hybrid and they're going to be home in 5 or 6 days and looking great, I'll say, let's go to surgery and let's get this taken care of. If I've got a 75-year-old patient who I think, with squames, we know that our perioperative outcomes with squames are not as good as with adenos. They're not as healthy. So if I've got a patient who I think is going to, get sick, we said, well, why don't we wait and prove that we have to do surgery? Though I think that one of the worst outcomes from surgery is that when you have a patient get sick or struggle or not recover, and we find on the pathology that they were a PCR, that's a bit of an error as well. So really the question here is we need better tools to delineate who has a PCR, not whether we should be doing observation or surgery for CCR, because you're asking a question of a black box. We need to get one step further, which is who really has a PCR or who really has systemic disease and who should we be avoiding surgery on.
Smithers, what would you do and why?
We would so in the discussions leading up to the surgery would be that you have a chance that you'll have a response. We won't be able to tell whether you have cancer there or not. And that at the moment, the data would suggest that you should have an esophagectomy. So when we go through this and they do have the situation, a CCR, then we discuss it with them, and we would be advocating they should have an esophagectomy. And if they say, what would you have? I say I'd have an esophagectomy. But they have the option of saying no. And if they do, then we would monitor them very carefully with endoscopy 3 monthly and PET scanning 3 monthly in the first year, 4 monthly, second year, 6 monthly, up to 4 years, and then finally at 5 years.
Okay. Would you do endoscopies and biopsies in those patients? And what frequency would you do it?
Yes. So I think there's data on the potential for the biopsy to be negative is really high, and the biopsy is not that sensitive. And so when you do an endoscopy and it looks like it's CR, when you biopsy it, usually there's nothing there, and then something happens 6 months later. When it looks like there's still something there, we would always biopsy that. If it looks pristine, I don't. But we use PET scanning And if the PET scan was abnormal, then I would do deep biopsies and I'd be looking to try to prove there's cancer there.
What if there was an abnormal, the biopsies are negative, there's a stricture?
So if there's strictures look malignant or they look benign, and we would gently try to dilate a stricture, being very careful, obviously, not to rupture the esophagus, but that's an uncommon situation that I've found. And I would be advocating to that patient they should have an esophagectomy anyway, and that would be a good reason to do an esophagectomy in my view.
So Yuko, can you give us a little bit the Japanese perspective? If you have clinical complete response after neoadjuvant chemoradiation therapy, what is your approach? A surveillance or resection?
Okay, so basically the patient is fit, and then the patient does not refuse the surgery. We do a surgery because we don't have any evidence to confirm the pathological clinical response. But nowadays, we just published data in Annals of Surgery. The case has a very good response, and they will show the recurrence just limited regional area from the main tumor. That means we can do a salvage surgery very safely. But still, we don't have solid evidence at this moment. We do a very intensive 3-4 months checking for this patient.
So we ended up with to go for surgery. This is a gentleman. Again, the gentleman asked me what we would do, and I would say I would take it out because clinical complete response does not translate always into clinical pathological complete response. We did a minimally invasive Iverlewis esophagectomy with supracranial dissection and intrathoracic anastomosis. And the final pathology revealed a YPT1B N1 with 1 out of 35 lymph nodes positive. As you can see, has a normal, this is his, normal squamous mucosa, and he has tumor in the submucosa. So what is the data for clinical complete response? How often is it pathological complete response, or how often is it not pathological complete response? I think you're looking at that now, aren't you?
Sorry?
Wayne? Are you there? Wayne is
I
not.
might comment on that. Wayne might have stepped out, but I think the reliability of CT PET in terms of its sensitivity is between 50 and 60%. So you're always taking a risk in these patients that there may be at least microscopic residual disease, and how that behaves, if left we're only finding out. We're taking risks all the time, but the sensitivity of PET is not great, but way better than it is for adenocarcinoma.
Very good.
I think
Sorry,
maybe
I got a question.
Wayne, the question is, what's the rate of, actually, Simon, we bypassed you, so it's Simon's answering that question. I'll get back to you, Wayne.
I think there is some data, a very good study from Chow from Taipei, who looks at the histological distribution of the residual cells in the esophagus after chemoradiation. And this sort of picture is really not uncommon. So often you have cells deep in the esophageal wall, but the mucosa appears to be intact. So it's very difficult to make a firm diagnosis of a complete response. I know the Prisano trial did this bite-on-bite biopsies, but still, I think that is difficult. In our data also previously, in addition to a complete response of the primary tumor, we have about 10% of patients with persistent lymph nodes outside the esophagus. So these are T0N+. And these lymph nodes are often microscopic. It's very difficult to diagnose. So I think currently there is still no, good way to tell whether it's a true complete pathological response for everywhere. Maybe Mark from Amsterdam can comment on the pre-Sino and the Sino trial.
Yeah, that's a good point, Simon. So I think the biggest problem with the endoscopy is, of course, not to diagnose a patient without any response, because those biopsies are accurate in 100%. In a partial response, it declines. But for example, in TRG2 patients, so the ones with only 10% viable tumor cells, the the prediction of even these bite-on-bite biopsies is really low. It's only 60%, so you still miss 40% tumor there. So it has to be some kind of a combined way of assessing this. And especially those patients that have a very, very little tumor load, of course, they would probably be considered to be curable at that stage. So we really don't know.